Anxiety. Anxiety is part of a mechanism developed in higher animals to handle adverse situations. The anxiety response can be conceptualized as part of the brain's alarm system firing during times of perceived danger. The characteristic responses, including avoidance, hypervigilance, and increased arousal, are implemented to avoid harm. The evolutionary drive to survive has invariably enhanced a strong anxiety response. Unfortunately, in many individuals, that mechanism is overactive. The alarm fires too frequently. Such people cannot seem to turn down their internal alarm, even when the coast is clear. The Diagnostic and Statistical Manual, DSM, system categorizes anxiety into a multitude of different disorders. Generalized anxiety disorder, GAD, obsessive-compulsive disorder, OCD, post-traumatic stress disorder, PTSD, and more. Although each disorder has unique clinical features, it is not clear whether they actually describe different pathologic states. The disorders have the following similar characteristics. Most patients with an anxiety disorder will have features of the other disorders. Many of the disorders respond to similar treatment interventions. Selective serotonin reuptake inhibitors, benzodiazepines, exposure therapy, and so on. There is little evidence to show that different disorders stem from different regions of the brain. Many people conceptualize anxiety as though there is a basic alarm system with many features in the brain. This system is overactive to perceived threat in patients with anxiety disorder. The Felt-T alarm generates common symptoms in patients with anxiety disorders. The one exception is OCD, which has unique mechanisms in the brain and will be reviewed separately. The body's reaction to an acutely stressful situation is well known to all of us. The characteristic rapid heart rate, dry mouth, sweaty palms are the body's response to increased sympathetic activity generated by a stressful situation. Less readily apparent are the endocrine responses to acute stress. In the late 1970s, Urson et al. Studied the endocrinologic responses of young Norwegian military recruits during parachute training. During the exercise, the recruits repeatedly jumped off a 12-meter tower and slid down a long sloping wire to learn the basic skills of parachuting. The training was designed to give the jumper a realistic sensation of the initial freefall. Measures of anxiety and performance skill, as well as serum hormone levels, were captured at baseline and after each jump. Initially, anxiety was high and performance was poor. As the days and number of jumps progressed, anxiety subsided and the skills improved. The endocrinologic measures are shown in figure 19.1. Presumably, the anxiety induces changes in the releasing hormones, which alter the pituitary hormones and ultimately the peripheral hormones. See figure 6.4. Note how testosterone levels drop with the stress of the jumping, while the other measures increase. Likewise, all return as the recruits habituate to the task to baseline. While the average individual shows a peak in the endocrine response at the start of a difficult task, which usually subsides as the person gains mastery, this is not true for everyone. Some people have more exaggerated and persistent endocrine reactions. Kirschbaum et al. Looked at salivary cortisol levels in 20 men exposed to 5 consecutive days of public speaking. For the total group, the average cortisol levels jumped on the first day and then gradually declined over the following days. However, the men could be divided into two groups, high responders and low responders. Figure 19.2 shows the cortisol levels for these two groups. Note how the cortisol in the low responders peaked the first day, but then quickly returned to baseline levels on the following days. These individuals appear to adjust rapidly to the stress of public speaking. The high responders, on the other end, showed higher, more persistent peaks of cortisol. Such people appear to have a harder time turning off the stress response. Presumably, they have a stronger alarm response originating in the brain, which is driving this endocrine reaction. Multiple lines of research identify the prefrontal cortex, amygdala, hippocampus, and hypothalamic pituitary adrenal axis as the regions involved with anxiety. See figure 19.3. However, if there is one organ that represents an alarm system in the brain, it is the amygdala. See figure 2.6. In their classic studies with rhesus monkeys in the 1930s, Heinrich Kluver and Paul Bucy identified the amygdala as an important region involved with emotions. They removed large segments of the temporal lobes from wild monkeys and transformed the monkey's temperament. Aggressive and easily frightened monkeys were changed into docile, calm creatures. The entire constellation of symptoms is called the Kluver-Bucy syndrome and includes a host of other bizarre features, such as hypersexuality and a tendency to put objects in their mouths. The transformation of the emotional behavior in these wild monkeys was most dramatic. The monkeys virtually became tame. They did not react fearfully to strange humans or even a snake. Of particular interest, the monkeys failed to learn from negative experience. One monkey, bitten by a snake, later approached a snake again, as if nothing had happened. This is clear evidence of the survival value of anxiety. In the intervening years, it has been demonstrated that the emotional changes of the Kluver-Bucy syndrome can be elicited with the removal of just the amygdala. Other evidence points to the amygdala as an important region in the recognition and management of fear. Electric stimulation of the amygdala in animals elicits fearful behavior, for example, freezing and tachycardia. Humans with damaged amygdala exhibit impaired fear conditioning. Functional imaging studies on humans show activation of the amygdala during fear learning. Sensory information enters the brain by way of the thalamus. For example, all neurons carrying auditory and visual information synapse first in the thalamus before being sent to the appropriate cortical region for analysis. Information about danger is particularly important and needs to be recognized quickly. Work by Ledoux et al. At New York University has shown that the amygdala quickly receives some preliminary information about dangerous events, even before it is processed in the cortex. Figure 19.4 shows an example of a person coming upon a rattlesnake. This life-threatening visual information proceeds from the eyes to the thalamus. However, the thalamus sends fast but rudimentary signals to the amygdala at the same time that the full information is passed back to the visual cortex. The amygdala, in turn, sends responding signals to the muscles, sympathetic nervous system, and hypothalamus. The person jumps even before being consciously aware of what has been seen. Ledoux has shown with rats that the fear response is preserved even if the neural connections between the thalamus and cortex are cut. In essence, the animal startles without knowing why. We have all had the experience of being frightened when seeing something, only to realize that it was just a shadow or rope, not a real threat. It is the fast track from the thalamus directly to the amygdala that causes this false alarm. This is considered to be unconscious or pre-conscious. We jump before we are aware. Patients with anxiety disorders can have exaggerated startle responses. They are burdened with an exaggerated unconscious reaction to possible danger. Some people dread personal interactions in which they will be the focus of attention. Typically, they fear they will embarrass themselves. The anticipatory anxiety can ultimately restrict their life path, limit their social life, and prohibit their career path. An imaging study looked at the activity in the brain of such patients who were asked to anticipate making a public speech. By subtracting the activity during anticipation from that at rest, they identified the areas of activity. Patients showed greater activity in their amygdala, as well as hippocampus and insula. Figure 19.5a shows the functional magnetic resonance imaging slice at the level of the amygdala. Anticipatory anxiety is not all bad. Figure 19.5b shows the hypothetical upside-down U-curve that many think represents the benefits and problems with anticipatory anxiety. Some anxiety is beneficial and actually improves performance. However, Too much of it is overwhelming and results in a poorer outcome. There is evidence that primitive, emotionally relevant memories are stored in the amygdala. For example, in rodents, long-term potentiation can be induced in the amygdala. Protein synthesis inhibitors injected directly into the amygdala will prevent the formation of fear conditioning. Chronic stress will induce increased dendritic branching in the amygdala. These results suggest that the typical structural changes that are observed with memory formation occur in the amygdala in reaction to fearful circumstances. This may be one reason why traumatic events are so persistent. Fearful experiences form quickly, and enduring memories then reside in both the neocortex as well as the amygdala. A small study in Sweden looked at the effects of cognitive behavioral therapy and the antidepressant citalopram on brain activity in patients with social phobia. Both treatments were equally effective, and both reduced the amygdala activation after 9 weeks of treatment. The degree of amygdala attenuation was associated with clinical improvement a year later. One of the central components of anxiety is the feeling that one is not in control. Patients will complain of increased anxiety when they lose control. For example, when the door closes on an airplane, when their social support drives off, or anytime they feel trapped. Feeling in control, on the other hand, calms anxiety. The ability to reappraise a difficult situation into more favorable terms is a function of executive control. Rational reappraisal is a central figure of cognitive behavioral therapy. The ability to cognitively master difficult circumstances and gain control likely resides in the prefrontal cortex. Clearly, the PFC plays an important role in managing anxiety. However, the exact prefrontal regions involved, lateral, medial, or orbital, are ill-defined, although the medial PFC gets the most attention. The medial prefrontal cortex, MPFC, which includes the anterior cingulate gyrus, is well connected to the amygdala. In a simple conceptualization, we can imagine that the MPFC applies the brakes to the amygdala. Several lines of evidence highlight the role of the MPFC in anxiety. Lesions of the MPFC in rats reduce the ability to extinguish fears. Stimulation of the MPFC inhibits a learned fear response. That is, the rat does not show anxiety. The MPFC lights up in functional imaging studies when fear is evoked in healthy subjects. Subjects with anxiety disorders have reduced activity in the MPFC. Taken together, these studies suggest that anxiety in part results from the reciprocal relation between the prefrontal cortex and amygdala. See figure 19.6. This has been shown clearly in a Cleaver study with traumatized combat veterans and firefighters. The subjects were shown pictures of faces expressing various emotions, while in an fMRI. The activity in the brain when the subjects were viewing the happy face was subtracted from the brain activity when viewing the fearful face. The subjects with PTSD were compared to healthy controls. Figure 19.7 B to D shows the results. Note how subjects with PTSD, under the circumstances of the study, show increased activity in their amygdala and decreased activity in their prefrontal cortex. In essence, they do not have enough activity in their PFC to turn down the activity in the amygdala. The hippocampus, an area involved with explicit memory acquisition, appears to interact with the amygdala during encoding of emotional memories. Although the exact role of the hippocampus in anxiety disorders remains unclear, it is an area frequently active in imaging studies during fearful situations. For a number of years, the reduction in volume of the hippocampus in patients with anxiety disorders has been an area of great interest. Several studies have documented smaller hippocampi in anxious patients, presumably due to the toxic effects of an activated HPA axis. However, a unique study with twins provides insight into the cause and effect of hippocampal volume. Gilbertson et al. Recruited 40 pairs of twins, in which one of each pair was exposed to combat in Vietnam and the other had stayed home. The researchers measured the hippocampal volume of each twin in an MRI. Additionally, the presence and severity of PTSD in the combat-exposed twin was assessed. As with previous reports, the twins who were diagnosed with PTSD had smaller hippocampal volumes, see figure 19.8a. However, the most remarkable finding was that the PTSD score from the combat-exposed veteran twin had a similar correlation with the hippocampal volume of the twin who had stayed at home. In other words, the best prediction of a combat veteran's level of PTSD and hippocampal size is not his exposure to trauma, but rather the size of his twin's hippocampus. This finding brings to light one of the great discoveries in neuroscience. It is the interaction between nurture and nature that results in mental illness. In other words, those at increased risk for developing PTSD are those individuals with a small hippocampus and exposure to trauma. Neither alone is sufficient. Taken together, these findings suggest an important role for the hippocampus in the development of anxiety. These early, preliminary data suggest that there is something neuroprotective about a large hippocampus that mitigates the development of PTSD, even when someone is exposed to unimaginable trauma. Possibly, a large hippocampus is better able to limit the acquisition of haunting memories, or more efficient at extinguishing them once they develop. Gamma-aminobutyric acid, GABA, is the major inhibitory neurotransmitter in the brain. Activating the GABA neurons calms down the brain. Too much activation causes sluggishness and even coma. The GABA receptor has several sites that bind with other substances, which has the effect of enhancing the inhibitory response of the GABA neurons. Figure 5.7 shows that ethanol, barbiturates, and benzodiazepines are known to bind with the GABA receptor. It is no wonder that people use and abuse these substances to calm down and reduce anxiety. Abnormalities in the benzodiazepine GABA receptor have been implicated as a possible cause of anxiety disorders. Results of the original imaging studies and more recent genetic studies suggest that alterations in the structure or concentration of the benzodiazepine GABA receptor may predispose individuals to anxiety. However, the hypotheses have not been consistently or conclusively established. The norepinephrine and E neurons with cell bodies in the locus coeruleus, see figure 4.5, are believed to be part of the stress response system and play an important role in anxiety. The following evidence supports this belief. NE neurons project to the amygdala. Stressed rats show increases in NE release. NE stimulates the release of corticotropin-releasing hormone, CRH, which in turn activates the HPA axis. Peripheral NE, the sympathetic branch of the autonomic nervous system, produces somatic symptoms of anxiety, sweating, dry mouth, racing heart, and so on. If the NE system is part of the anxiety response, why does blocking NE reuptake and consequently increasing NE at the synapse relieve anxiety? How can more be less? For example, antidepressants such as the highly noradrenergic imipramine and the NE reuptake inhibitor reboxetine are known to reduce panic attacks. This does not make sense. This paradox highlights that our understanding of anxiety and how the antidepressants calm the nervous system are in need of further study. Most likely, the antidepressants reduce anxiety by growth or increased strengthening of inhibitory networks. The ability of brain-derived neurotrophic factor, BDNF, to stimulate nerve cell growth has been addressed in many chapters: adult development and plasticity, anger and aggression, sex in the brain, depression. It is hypothesized that antidepressants work in part by boosting BDNF production, which in turn stimulates cell growth. However, recent work from Nestler's laboratory shows that not all BDNF is therapeutic, and some may actually play a role in the development of anxiety. Using the same social defeat model with mice, described in the depression chapter, the researchers developed mice that displayed features of anxiety, fearful around strange mice, socially isolative, and so on. Much to the amazement of the researchers, these defeated mice showed increased BDNF in their nucleus accumbens, NAC. The team was then able to eliminate the BDNF production in the NAC. They injected a virus that knocks out BDNF production into the neurons that supply the NAC with BDNF. These mice acted normally around strange mice and did not display any anxious behavior. Similar results were found when defeated mice were given imipramine and fluoxetine. Mice given the antidepressants or having their BDNF production knocked out failed to display anxious behavior after 10 days of social defeat. In summary, this research implies that the development of anxiety that usually results from trauma might occur through the production of growth factor proteins in specific regions of the brain. Depression, on the other hand, might be the result of the lack of growth factor proteins in other regions. Remarkably, antidepressants seem to limit the expression of BDNF in the NAC while increasing it in other regions, such as the frontal cortex and hippocampus. OCD, or obsessive-compulsive disorder, is classified as an anxiety disorder in the DSM nomenclature. However, some clinicians conceptualize OCD as a different kind of disorder. They see OCD as one extreme of a spectrum of repetitive behavioral problems: body dysmorphic disorder, certain eating disorders, gambling, and even autism. These conditions are frequently called OC spectrum disorders. Regardless of the nomenclature controversy, OCD is unique among the anxiety disorders because it is driven by a different neural activity. This was first noticed in the 1930s by the behavioral sequela after von Economo's encephalitis pandemic from 1917 to 1926. Patients who had recovered from the original infection were often inflicted with Parkinsonism or OCD. The basal ganglia were implicated. Symptoms of OCD are also seen with other disorders that affect the basal ganglia: Tourette syndrome, Parkinson's disease, Sydenham's chorea, and so on. Early adverse experiences have a significant impact on the later development of anxiety. Harry Harlow established with monkeys the profound negative impact of being raised without a mother or peer relationship. He replaced the mother of infant rhesus monkeys with an inanimate surrogate object during the first months of life. The infant monkeys displayed long-term deficits in social adaptation, as well as increased anxiety-related disorders. We have discussed examples in which early experience changes neural structures. For example, the following have been observed. Rats raised in standard wire cages have less dendritic branching than those raised in an enriched environment. Licking and grooming by the rat mother affects the pup's response to stress. Children raised in Romanian orphanages have lower IQs. A recent study looked at the effect of breastfeeding on anxiety in humans. Children whose parents separated or divorced when the children were between the ages of 5 and 10 years were assessed for anxiety when they turned 10. The children who were breastfed had less anxiety and more resilience in response to the difficult circumstances. Although there are no details about the effects of breastfeeding on the brain, the results of this study seem strikingly similar to what Michael Meany found with his Hylic and Groom mother rats. Therefore, the extra attention at an early stage of life may be neuroprotective. The basal ganglia are subcortical structures that are usually associated with movement and motor control. Disruption of the basal ganglia leads to such disorders as Huntington's disease, Parkinson's disease, and hemiplegismus. However, the exact function of the basal ganglia in OCD remains unclear. The basal ganglia are made up of interconnected nuclei, the caudate, the putamen, and globus pallidus. The caudate and putamen together are called the striatum and contains the NAC. Many areas of the cerebral cortex send projects to the basal ganglia that passes the signal to the thalamus, which in turn ultimately sends a signal back to the cortex. The loops that the signals take have sizable names, such as corticostriatothalamic cortical circuits. Functional imaging studies of patients with OCD while they were obsessive have repeatedly shown increased activity in the orbitofrontal cortex, anterior cingulate gyrus, and basal ganglia. It is presumed that circuits between these structures are active when patients are obsessive. However, the particular circuit may depend on the particular ritual. Washing, checking, or hoarding seem to activate slightly different regions. Likewise, treatment interventions, whether with medications or psychotherapy, show decreased activity in the basal ganglia for those who respond. Medication and psychotherapy alleviate anxiety through different mechanisms, but with equal effectiveness. Combining the true treatment modalities is generally believed to be more efficacious than either of them alone, although this has not been conclusively established. However, some clinicians wonder whether medications limit the learning that is essential to effective psychotherapy. There are only 3 large combined psychotherapy medication studies for the treatment of anxiety disorders that have long-term follow-up after stopping the medications. Alprazolam and exposure therapy alone and in combination for panic disorder, exposure therapy and sertraline in social phobia, CBT, imipramine, or their combination for panic disorder. In all 3 trials, one outcome was the same. When the medication was stopped, the group that received a combination of medication and psychotherapy deteriorated relative to the group that received psychotherapy alone. Figure shows the result for the CBT imipramine study for panic. Studies have shown that extinction results from the development of new memories, rather than the erasure of the old, fearful memories. Does medication limit the development of new memories that are required for effective, enduring psychotherapy? These studies suggest that some therapeutic changes that usually occur in the brain with psychotherapy are impeded by the presence of the psychoactive medication. There is a long and troubling history of attempts to treat mental illness with neurosurgical interventions, such as the prefrontal lobotomy. Consequently, many are reluctant to even consider neurosurgery as a treatment option for psychiatric diseases. However, there is good evidence that some limited procedures with treatment-resistant patients can diminish OCD symptoms. Different techniques are preferred in various regions of the world. In the United States, the popular technique is anterior cingulotomy, which is based on the concept of interrupting the circuit between the anterior cingulate gyrus and basal ganglia. Figure 19.11 shows the location of the lesions in post-surgical MRI scans. Follow-up studies find that approximately 30% of the anterior cingulotomy patients have a 35% or greater reduction on the Yale-Brown obsessive-compulsive scale. Complications include seizures and urinary incontinence, but appear to be infrequent. A different technique used more regularly in Europe is anterior capsulotomy. Although this procedure seems to be more effective, it is also associated with more complications, for example, cognitive and affective dysfunction. More recently, deep brain stimulation has been studied as a way to treat severe and intractable OCD in a manner that is reversible and more flexible.